there is distension of the gallbladder, and when the distension is full, the stone slips back and the pain subsides. So this is not a colic. This is actually nothing but a dull aching pain. The only difference is that the duration is only 2 to 3 hours. But if the pain is caused due to complete blockage and the gallbladder distends, in that case, it will be a persistent pain which goes on for more than 12 hours, and then we call it an acute cholecystitis, and this is associated usually with nausea, vomiting. The third pain is that of chronic pancreatitis. Again, that's a dull, aching, boring pain that occurs, and as you all know, it radiates to the back. So these are the three basic types of pain, and when you go for the exam, it is extremely important that you remember all of them. You just vomit it out in front of the examiner, the character of pain in APD, chronic cholecystitis, and chronic pancreatitis. Then, of course, comes the difference between chronic duodenal ulcer and chronic gastric ulcer. And as you know, the chronic duodenal ulcer, the pain is increased in empty stomach, whereas in gastric ulcer, it is increased on taking food. Now, one must remember that, therefore, the pain occurs mostly in the early morning, whereas in GERD also, the patient gets up in the morning, but it is around 12 to 2 a.m. in the morning, whereas these patients are going to have pain somewhere around 5 a.m. That's very early morning, so that 5 to 6 hours of fasting is there for the pain to come back. Classically, both of them will have a periodicity, and there is a variation according to weather, and most commonly they occur during times of springs and autumn. And in the first case, you see the pain, once you take food, the pain subsides, and therefore these patients have got a tendency to increase in weight. Whereas in this patient, the food increases and often they resort to vomiting, and therefore they will have a sort of weight loss. So these are all known factors. I'm not going into the details of them. But what are the variations in pain? Now this is an important question. Now, number one, there's a gentleman who presents with a pain, and this is important during the exam, that you are going to tell that in the lifestyle of this patient, say if we draw a chart, say 5 years, and the patient in the first, second, third, fourth, and this is the 5th year. In the first year, the patient might have 2 episodes of exacerbations. The second year, it might have a longer duration. From 3rd year, it is becoming longer. From 4th year, you will find that it is becoming almost like this. And then the pain has lost its periodicity completely. So you need to understand this loss of periodicity of pain over a span of period of the natural history of the disease will give rise to the possibility of being a pyloric stenosis. Whereas the another important factor that might have a pain of chronic gastric ulcer which changes into a new onset classical continuous pain might be again a sign of gastric carcinoma. So this character, when you are presenting before the examiner, has to be very carefully placed. That means the patient was doing fine and he was doing excellent for the last 5 years. There were periodicity of pain. The pain used to come back in the autumn and in the spring, and the patient used to take the pantoprazoles for almost 4 or 5 years, doing fine. In the last 1.5 years, he started losing his periodicity, and now the patient has continuous pain and is relieved only on vomiting out. And therefore, this loss of periodicity is a characteristic feature of changing towards pyloric stenosis. The third important character is that of perforation. And here, it's needless to tell that all of you will know this, but again, during the exam, these are very simple things. When you read very much about the carcinoid tumors and cystic neoplasms, you tend to forget your basics. So you must tell that the pain initiates here, then the pain goes down, just brushing up your knowledge, it goes down along the right paracoelic gutter, then it goes here, and they finally mix, and then therefore a period of remission. So first, this pain that goes along this direction is a pain which radiates from the the epigastric region along the paracoelic gutter towards the pelvis. So the phase of radiating pain is there. And this is followed by the period of remission. And then finally the pain comes in the whole abdomen. That is the pain of peritonitis. So again, during the exam, these are very basic things which you cannot forget. Because if you forget this, I can assure you the examiner is not going to forgive you. The next important thing is penetration. Now try to understand what is penetration. Now penetration is a condition where this is the stomach and this is the pancreas. So with time there is an ulcer there which goes down into the pancreas. So these patients are going to give you a history of a pain in the epigastrium, and this epigastric pain gradually goes towards the back, and the characteristics are very much like of chronic pancreatitis. So it mimics pancreatitis. So when a patient gives you a history that I was having pain which was relieved on taking food and on taking pantoprazole, and it was there for around 3-4 years, of late I find that the pain is going towards my back, that must give you the clue that possibly the ulcer is penetrating behind into the pancreas. Now comes the next important thing, vomiting. Again, it is important to understand that there are two facets. Now, most of the patients who are presenting with a chronic duodenal ulcer will have, now most of you, those who have encountered this chronic duodenal ulcer occurring due to stress during the exam, might have noticed that there are episodes of pylorospasm. So this is the ulcer, and there is a sudden pylorospasm, and there are episodes of 1 or 2 episodes of vomiting. I mean, if that episode of vomiting occurs, that are perfectly normal. I mean, this can occur. This is not a sign of gastric outlet obstruction. With time, again, if you look at a timeline graph, you find that 1, 2, 3, 4, 5. So in the first year, the patient will tell that during the autumn, I had exacerbation of pain, and I used to have 1 or 2 episodes of vomiting during attacks of pain. That's perfectly normal, but it wanes off when the winter season comes, and he is absolutely pain-free, vomiting-free. But what happens is that in the next year, it might have 1 or 2 episodes. But as you go into the 4th and the 5th year, you will find that there are multiple episodes. And finally, the classical thing comes by the end of 5th year. And the patient is going to tell that, doc, I can take liquids. If I take solids, it doesn't go down. And I usually vomit initially twice a week. Then almost every day towards the evening, I vomit out, or in alternate days, I vomit out. And as I vomit out, what happens is that it contains undigested food material and is associated with bad odor. Now you need to understand that during the exam, in front of the examiner, if you're getting a benign gastric outlet obstruction, you must establish this change in pattern of vomiting to intermittent, maybe 1 or 2 episodes per year, to an episode every day. And you must be able to establish the whole thing. So this is number 1, establish the change in pattern and frequency of vomiting. So this is 1, the pattern and frequency. Number 2, in front of the examiner, you must be able to establish that this is not a bilious vomiting. This is a vomiting of clear-cut duodenal ulcer. and therefore the content, which most of the patient will tell sour to begin with, and it leaves behind a stain if they happen to vomit it on the floor. Whereas bilious vomitings will be greenish, and as you know, it is bitter to taste. Again, I am repeating, this appears very basic, but these basic facts are missing. And I have been examining for the undergraduate level, the MS level, the national board, as well as the MRCS now. So I have seen candidates meeting the very basics, and if they are asked to explain a particular vomiting, they are unable to do so. So therefore, the pattern and change in frequency, the character of vomiting, the content of the vomiting, everything determines whether you are dealing with a gastric outlet obstruction. Now comes the other important aspect. Now, many of your patients are going to tell that, doc, I can feel a mass in the upper abdomen. And when you touch this patient, you don't find a mass. So the question is, what you are going to utter during the exam, that becomes very important, because most of these patients will have distended stomach. So the terminology which I would ask all of you to utter is fullness. So even in the chief complaint or in the history of present illness, you are going to tell that this, you do not tell that number one, the patient has pain, number two, patient has vomiting, and number three, patient has a lump. If you tell lump, then the examiner is biased towards a diagnosis of a gastric carcinoma. But if you are telling that there is a fullness, and this fullness is intermittent and mostly prominent after taking food and is associated with some movement, then you are making the examiner bias about the fact that you are dealing with a gastric outlet obstruction. And it is not really a mass, but it is a fullness or a distended stomach, which is presenting as a fullness, and the cause is due to gastric outlet obstruction. So the terminology that you are going to use is fullness and intermittent and distended, and therefore you are directing the examiner to the fact that this is not a mass, which would mean that it is possibly a carcinoma. The next question that comes, of course, that is an important aspect of this, and you know, all of you have gone through these MCQs, and whether you are appearing for the MRCS exam or whatever it is, people are going to ask about the patterns of dyselectrolytemia, acid peptic disorder, and in perforation, you know, it's a simple hypovolemia with hyponatremia and hypokalemia, and later on it can lead to hyperkalemia if the patient develops a renal failure. But the question comes in a gastric outlet obstruction. And all of you know, and if I divide it into stage 1, 2, and 3, in stage 1, of course, the patient vomits out water, so water loss is there, so hypovolemia is there. The patient has got a vomiting of HCl, so there will be the hydrochloric acid is going to decrease, and therefore the patient has dehydration, alkalosis, and reduced calcium. This would mean a urine which is going to be alkaline, and it is because there is loss of bicarbonate and associated with the loss of sodium. In stage 2, as this loss continues, water and hydrochloric acid, as dehydration continues, as alkalosis continues, and as hyponatremia continues, there is renal hypoperfusion. And once there is renal hypoperfusion, immediately what happens is the aldosterone axis is stimulated. And if the aldosterone axis is stimulated, what it would mean is it would start retaining the sodium. And if they retain the sodium in the next stage, this would be in place of potassium loss and hydrogen ion loss. And that would explain the reason why there is paradoxical aciduria in spite of the patient having dehydration, alkalosis, and decreased calcium level. The patient is going to have, and actually the alkalosis leads to hypocalcemia. So the paradoxical aciduria is explained by the fact that there is persistent hyponatremia and there is persistent water loss that would lead to renal perfusion and which would lead to a paradoxical aciduria. Again, then this is a very pet question for Viva and those who are appearing for the tables in MRCS or for the National Board exam. This is a very pretty simple question which everybody must know. Now coming to the hallmark clinical signs, which is extremely important. Number one, as I said, is the confusion between lump and swelling. And believe me, I had, as a student like you, was extremely perplexed whether to tell it as a lump or it's a swelling. Now, I would believe that if I find a lump, it has to be a discrete one, a very discrete one. And you must be able to tell the superior margin, the inferior margin, the left lateral margin, the right lateral margin, the surface, etc., etc. Whereas a swelling or a distended stomach would feel like a fullness. And a very important way to differentiate between the two will be by succussion splash, of course. But before that, this is going to be firm. This might have a dullness, whereas this is going to be soft, and this might have a resonant note. So that is going to differentiate whether you are dealing with a lump or you are dealing with a swelling. But if you find that the patient has got a peristaltic movement from left to right, that actually is the sine qua non, and that would actually fix up the whole matter that there is a visible peristalsis, which is usually missing in gastric cancers. Again, the question comes again, going back to the basics, you may be asked why not it's a colonic peristalsis, and you are going to repeat the same old thing that you have learned in your undergraduate school, that is the movement from right to left or the movement from left to right, and it determines whether it is colon or you are dealing with the stomach. The hallmark number 2 sign that is a mandatory must is a succussion splash and an ausculto percussion. Now try to understand, this is a test which is there, but not a very common finding throughout the globe. But when you are trying to elicit this test, you have to be very, very gentle, because the patient might feel some problem while you are doing so. And therefore, the technique that you are going to do is put your stethoscope up here and move the patient very gently. And the common question that is asked, what are you going to ensure? You are going to tell, I am going to ensure that the patient has not taken any fluids at least 2 hours before I am examining the patient. That is an important thing. Though, of course, in a whispering note between you and me, you can poke your patient to take a glass of water unofficially while you are demonstrating that. That is going to demonstrate perfectly a succussion splash. The second important thing, of course, is the ausculto percussion. And you place the stethoscope and you do it from there and you mark it like this. As you go, the change is tone, and you are going to mark it the way it is being marked. Now this marking is very important. I am going to tell you why this marking is extremely important. You know this test. Why this marking is important is because of this. Now try to understand, ausculto percussion is a surest test to tell that there is gastric outlet obstruction. There are 3 different ways. Number 1, the patient is sitting. Number 2, the patient is in supine position. If the patient is sitting in a sitting position, normally you will find that the stomach can go up to the level of the umbilicus. It can go normally up to the level of the umbilicus, but it should not go beneath the level of the umbilicus. So in the sitting posture, if the stomach goes beneath the umbilicus, that is a dilated stomach. In a supine position, when the patient is lying down flat, the stomach normally is situated above the midpoint between the xiphisternum and the umbilicus, so the stomach is usually above this. If it goes beneath this, there is a high suspicion that there is a gastric outlet obstruction. But if it goes beneath the, beneath the umbilicus, that is a gross gastric outlet obstruction. So this is level 1, this is level 2, and this is level 3 to tell that the patient's stomach is grossly dilated. And that is again a reason to tell in front of the examiner that you are dealing with a gastric outlet obstruction. And so therefore, this test becomes very important. Now, what is the provisional diagnosis? Now, coming to the provisional diagnosis, you are going to tell that it is a gastric outlet obstruction. Either it is benign or it is malignant. Now, a benign gastric outlet obstruction, you must be able to, as I was telling, characterize the pain course. That is very important. I mean, how it started, how it lost its periodicity, and how it became a persistent pain. That has to be presented in front of the examiner. Number 2, the course of vomiting. How it started to small episodes and it lost its frequency, the frequency increased to become a persistent vomiting. So these are the 2 important differentiating points in cases of a gastric outlet obstruction of benign origin and that of a malignant origin. Add to this anorexia, asthenia, and weight loss, which is usually missing in anorexia, asthenia, weight loss. While weight loss can occur to a certain extent because of the prolonged illness, but none of these patients are going to tell you, doc, believe me, I have lost my appetite. They have got the appetite, but they are afraid of taking food because of the tremendous vomiting they have. Whereas a patient of malignancy is going to tell you, you put food in front of him, he would just not look at it. So these differences are important in establishing whether this is a benign or it's a malignant condition. The third important factor is lump is a characteristic feature in a malignant condition, whereas a benign condition, as I said, it's a fullness with peristalsis, as I said, from left to right. So again, of course, in certain cases, it can occur in malignancies as well, but malignancies by and large and by rule will not progress so slowly so as to have a stomach which is become atonic and which develops to this extent, and most of them are going to present to you with these symptoms. So as I said, presence of fullness and peristalsis from left to right are more in favor of benign disease than in case of malignant disease. Now coming to the complications. Now, as I said, this is again an important issue, and you know, all of these are questions. I mean, bleed is a question, perforation is a question, penetration is a question, and I hope once again you will remember, because not the common books that you read today. Most of you read the Western textbook and they do not have these chapters who deal with in details about chronic duodenal ulcer and its complication, because that is something which is gradually evaporating from the field of surgical science. And of course, gastric outlet obstruction. And you must be able to tell this is a characteristic feature of chronic gastric ulcer and is never present in case of chronic duodenal ulcer. So that is something. And of course, as I said, any of the questions, the examiner can drag you to upper GI hemorrhage and how to deal with it. And again, when you cause of bleeding, you must be able to tell all the causes and must be able to answer these questions. Perforation, again, you know, and you would be able to tell that. Penetration, how you're going to manage the penetration, I'm going to tell later on. Gastric outlet obstruction, the important question that is asked in these circumstances is the dyselectrolytemia and how to prepare, and then of course how to manage. But preparation comprises a very important facet, and you all, I'm sure, will be able to tell based on the dyselectrolytemia that a patient presents. Now coming to the diagnosis. Now these are 5 very common conditions. One is a chronic duodenal ulcer, the second is a chronic gastric ulcer, number 3 is a carcinoma, number 4 is a lymphoma, and number 5 is a gastrointestinal stromal tumor. The question is, upper GI endoscopy, how do you differentiate them? Number 1, of course, is the one that you see. It goes into the first part of the duodenum. So that makes it very easy, and this is excluded. Now comes an ulcer in the stomach, and that would mean a chronic gastric ulcer, a CA, a lymphoma, and a cyst. Now try to understand what happens. The basic pathology between a chronic gastric ulcer and a CA is when an endoscopist or a gastroenterologist puts in the endoscope inside. In a carcinoma, it is usually a non-distensible stomach. So that is something you must remember. Number 2, this is a distendable stomach. Number 2, if this is the crater, what happens? If you look at this, this is submucosal. I mean, if you look from above, there is no proliferation, but there is something which is going outward. Whereas this is usually heaping inside the lumen. Number 3, this is going to have convergence of rugosities. And this is going to have loss of rugosity all around. Number 4, this is going to be mostly on the lesser curvature of the stomach, whereas this is likely to be more on the greater curvature of the stomach. This is likely to be less than an inch in size, and this is likely to be more than an inch in size. So again, this is a sort of revision that you remember these particular points that makes it different between a gastric ulcer and a gastric malignancy. Now try to understand, there may be a conversion of an ulcer to a cancer, but the basic thing is the inward growth, the fact that it has got a proliferation towards the lumen makes it a possible cancer than an ulcer. Now again, try to remember, there is only one condition. There is only one condition where, in spite of the fact that this is malignancy, you won't be able to ascertain it with an endoscopy, and that is when you have a linitis plastica or a leather bottle stomach. So what happens is that the whole stomach is shrunken and small, and therefore you put in the scope, you may not find an ulcer, but it is the characteristic thing, the rugosities are lost. You are putting in a scope, you are unable to see the rugosities to the extent that you normally find. You are unable to distend it. You feel that it's a non-capacious stomach. The only condition where endoscopy fails and barium scores or a CT scan will score is in linitis plastica, where it would be able to tell you the thickness of the stomach wall or the non-distensible character of the stomach wall, and therefore linitis plastica is the only exclusion. By and large, you'll be able to tell them. Now comes the question of lymphoma and cyst. Now what happens in lymphoma is, if you look at the stomach, what you are going to find is the stomach is like this, but there is a smooth bulging. So it looks a smooth bulging, the stomach is bulging, but there is no ulceration obvious, like the one that you find here. At times you might get an ulcer, and that is called a starry stomach. That means you look at it and you find that someone has sort of put in something into the center, and that's because the lymphatic tissue is gradually stretching and the mucosa might break at a point where this distensibility is lost. And these group of patients might bleed a lot. So a lesion which is submucosous, and quite often you have multiple bumps and nodules like this, to tell it's a lymphoma, and you might have an ulcer like this. Whereas finally coming to gist, you can have an unifocal area of where you can see some sort of bulge, but the lumpiness and bumpiness of lymphoma is missing. And therefore, in these cases, CT scan is going to give you more information than the endoscopy itself. And taking a biopsy, most of the gastroenterologists will be very careful in taking a biopsy in these two conditions because of the chance they do not know the depth, and they are afraid because while going into the submucosal space, they might perforate. So the question comes is, where exactly you take the biopsy from? The biopsy, when you look at the ulcer like this, you divide it into 4 quadrants. And I would recommend you take biopsies 2 from each zones. So at least 8 biopsy specimens have to be taken, and they are to be taken from each zone at the margin. And that is how you are going to differentiate between the two. Now, barium study, again, the reason I am, as an old man, presenting in front of you about barium study is because I have learned it by heart during my undergraduate and postgraduate days. And unfortunately, the older generation continues to take the exam. And therefore, they would be tempted to ask you these questions about barium studies as a historical archive. Again, you must tell that step 1, in stage 1, when you do a barium, you may not have anything, but the ulcer is there. So if you want to add and actually visualize the ulcer, you can have something called hypotonic duodenography. We used to have that. And that is, you add a hypotonic agent so that the stomach now is relaxed, and you add a thin emulsion of barium, and which should show you the ulcer niche in the first part of the duodenum. Gradually, the whole thing, it might go into, as it goes into fibrosis, it can develop something called a trifoliate or a bifoliate deformity, whereas a normal stomach will have a pylorus looking like this. A bifoliate or a trifoliate deformity would give rise to the suspicion of pyloric stenosis. And this finally will lead to non-visualization. I mean, it is completely cut off. So it can start with finding a small ulcer niche in the stage 1, 2, a bifoliate deformity or a trifoliate deformity in stage 2, 2, non-visualization in stage 3. In case of gastric ulcers, the same thing might happen, but here it is usually a more clearly obvious ulcer that you can visualize. So if you can see this ulcer, which is usually and classically situated on the lesser curvature and less than an inch in size, with a submucosal pattern, that is, it is eroding into the submucosal, you think it is a gastric ulcer. And as I said, in malignancy, you need not do this, and you're going to find something like that. So malignancy is not an issue. Having said that, I must confess that this is not the common presentation or the tool to be used during the exam, except, as I said, in cases of Linitis plastica, where it's a shrunken little stomach, which would raise the suspicion more than an aperture endoscopy where it may not be any ulcerative lesion. But whatever findings we find here is replicated today in CT scan. And therefore, if you are asked the CT findings, you can jolly well tell about the CT findings plus the other findings, that is thickness, the metastasis, blah, blah, blah. Now, an important aspect, a very important aspect is in barium is to understand the gastric anatomy. The question is how you understand the gastric anatomy. Now, a normal stomach would like to be a sphenic stomach like this. Now, if it develops hyperperistalsis, the stomach axis gradually becomes more upwards. Whereas as the stomach becomes more atonic, the stomach axis changes to something like this. So it is like this, 2 it is like this, and 2 it is like this. So as the stomach curvature straightens up, as the axis becomes more straight along the line of xiphisternum, you can gauge, apart from the fact looking at the dilated stomach, you can gauge that this is an atonic stomach. And the reason I would tell why an atonic stomach is important in these patients doing any surgery might lead to a gastric peristaltic failure, and we call it postoperative gastric atony, and which can be a notorious situation to deal, and that is because of gastric atony. Today we have nuclear physicians to help it out, but though not common. But if you suspect, a CT scan or even a barium can tell you about the gastric atony that is obvious. Now coming to the indications of acid peptic disorder surgeries. Now the question is it in the archives now? Now I do feel in the West it is in the archives, to be very frank, and very few patients are going to come back to us for surgery. But as I said, when we were postgraduates in the mid-1990s, I mean, I have seen and look at the great dons of surgery who would use their fingers, or they are going to use a right angle to take out the vagus nerve in one go. And of course, again, I share between you, I have seen quite a number of them taking out the rice tube as well, thinking it to be stomach. But that was an era where there were no pantoprazole. People were relying with the early arrival of famotidines and ranitidines, and therefore surgery for gastric, a duodenal ulcer was there. And in those era, it was said failed medical therapy. And it was a classical teaching that if there were 6 weeks and 2 therapies failure, that is an indication for surgery. Now, of course, I have seen people who have been using them almost the age they are. I mean, I have seen people using it for 12 years. I don't know whether those patients are going to come back with enterochromafinoma or not, but people are using that and they are sort of gone into some sort of adjustment with the disease. The question comes, you are dealing with a peptic perforation. Are you going to do a definitive surgery? That is an important question during the exam. The answer to the question is no, if it is analgesic induced. Yes, if there is a definite, prolonged history of ulcer disease and the patient presents to you early, and the criteria is 1, at less than 12 hours, at less than 40 years of age, and no comorbidities. So that means a 38 years male who had a perforation in the morning had come to you with emergency with a history of duodenal ulcer for 2 to 3 years, and you could find that there is a small little ulcer or area of duodenal ulcer over which it is perforated, you can choose to do some sort of ulcer surgery. And if the patient has an outlet obstruction, you can choose to do it. However, in most likely situation, most of them will be presenting late, and therefore only a perforation surgery is good enough for them. Now the question that is asked during the exam, what percentage of patients will need a definitive surgery later on? And the answer to the question is only 40% of them will come back for an elective definite procedure. 60% of the cases, as you deal with the perforation and put the patient on long-term pantoprazole, if there is no gastric outlet obstruction, they will not require an elective surgery in 60% of the cases. Now today again, gastric ulcers, you initially a confirmed biopsy proven gastric ulcer which matches all the clinical endoscopies and a biopsy proven evidence of a prepyloric ulcer. You can choose to have a medical therapy, but if you have any doubt, a surgery becomes must. Gastric outlet obstruction, no issues, you need a surgery. And we are going to discuss what surgery we are going to use it. Penetration to the pancreas, again you need a surgery in most of them. We are going to discuss what surgery we are going to use. Now bleeding, again it depends. What is the cause of bleeding? Is the cause of bleeding due to a long-term definitive ulcer which has been bleeding and there had been multiple episodes and multiple recurrences? Then of course you can think of a definitive procedure. But if the patient happens to come with, say, an analgesic-induced bleed or some acute bleed, in those circumstances, the question of definitive surgery doesn't exist. Now, coming to the pyloroplasties. Now,
So why in analgesics we don't do surgery, sir?
Can you mute yourself, please, dear? Thank you very much. Now, pyloroplasties. Now this is, I can assure you with certainty, is an obsolete procedure. Nobody does this anymore. However, once in a while you might get a patient where you have to do it, or you might be getting a patient where you have to do a sort of a part of Siguria procedure where you do an esophageal transection. You might have to do a pyloromyotomy or a pyloroplasty in some of them, or else a pyloroplasty is a rarity now. If you choose to do, there are certain procedures. Number one is called the hynetomedulis procedure, where you cut along the length and then you suture it in this direction. So basically, you are widening the pylorus. And that is because you have cut the vagus. The second is something called a finesse procedure. Now, what is a finesse procedure? A finesse procedure is basically a gastroduodenostomy, where you make a prolonged cut like this. And as you make a prolonged cut, you are going to sort of wrap the duodenum on the stomach. So this is basically a gastroduodenostomy, which is known as a finesse gastroduodenostomy. Again, it is associated with truncal vagotomy. Now, these are procedures which people used to do in era where vagotomy was the treatment of ulcer, and there are no such evidences of gastric outlet obstruction. If you have an evidence of gastric outlet obstruction, as I said, this procedure doesn't have any role. So I have seen candidates making small mistakes during the exam. I mean, we have asked them, now this is a patient of benign gastric outlet obstruction. What are you going to do? And they started like an MBBS student telling, sir, we can treat it by a truncal vagotomy with either a pyeloplasty or a a gastroduodenostomy. Now, need to understand, this is not done. I mean, if you are having a patient with gastric outlet obstruction, neither hynocomegaly nor fine is going to help you out, and they will require a bypass for sure. So it brings us to the next part, what bypass? Now, if you look at vagotomy as a procedure, now what are the important facets of vagotomy that you must remember? Of course, most of you know that the vagus has got two branches, and it goes like that, and it goes and supplies like this. So the terminal one has got a crow's foot or a divergent spoke like an octopus, whereas these has got perpendicular branches going like this. So that is the anatomy of the vagus. Either it's the anterior or the posterior. And people have experimented again with trying to keep this much. So the question is, how much is to be kept? People have kept 2 centimeters, and the patient came back with outlet obstruction. The people have kept 8 centimeters, and again, it didn't move. I mean, the ulcer came back, and so there was recurrence. So they kept down to something between 5 to 6 centimeter terminal crow's foot is the optimum amount of the crow's foot to be kept if you're trying to plan a HSV, which is known as a highly selective vagotomy, or if you try to do it laparoscopically, a very simple technique would be to cut all these, and some people named it as seromyotomy. And of course, you have the choice of doing a selective vagotomy, which nobody does. It is an obsolete. I think it came for a month only and went off. So what is done is a truncal vagotomy. Now the question is, if you are doing a truncal vagotomy, what is important? Now, this is what is extremely important. The vagus nerve is going to come down like this. Okay, and most of you will think that cutting this vagus and the posterior one is going to be wonderful. And I have seen people, as I said, putting in fingers or using a right angle and taking the vagus and cutting it. So what points you need to remember? Number one, I must remove a segment at least an inch of anterior and the posterior vagus. Number two, the posterior vagus usually is associated with phenikomitance, and it might ooze. So even if you fail to ligate the anterior one, the posterior one has to be ligated. Number three, this whole area of the lower esophagus has to be completely made raw and bare. I mean, if you see anything white structure in the lower end of the esophagus up to the G junction, everything needs to be removed, and that is called create a raw esophagus. A very important component of recurrence is the criminal nerve of Grassi. And what the Grassi does is it comes like this and goes behind to supply the fundus of the stomach. That is the reason it's criminal. It remains hidden. So unless you remove or denode even the fundus of the stomach, so the whole zone has to be made bare. Just putting in something called a right angle or taking it out with your finger doesn't make any sense, and that would be associated with a high rate of recurrence. And I have seen in good old days, at least 2 decades back, people using pantoprazole after they have done a truncal vagotomy and gastrojejunostomy. For you to answer the question, it has to have a segmental removal, the posterior esophagus mandatorily must be tied, and the lower esophagus has to be made raw. And you must look for the criminal nerve of Grassi. So for that, what we would recommend is, if you have the esophagus, what I do is I put in a sling like this and I draw it on both sides. And posteriorly, as if you put the stomach out, you get the crust and you find the esophagus, the vagus just lying there. It becomes very easy. But having said that, in today's era, if I do a truncal vagotomy, I would always do it laparoscopically, because that makes it so easy for you to identify, to make all the dissections and go up to the lower part of the esophagus. If I wish to go up to the certainly to certain extent into the thoracic component, it becomes very easy visually as well as technologically. So people today, if they choose to do a vagotomy, unless I am training in open procedure, but as I said, there is no point training somebody in an open truncal vagotomy, because truncal vagotomy laparoscopically is so easy. So one must be doing only laparoscopic truncal vagotomy. And then if you choose to do a gastrojejunostomy as a bypass procedure, you can use an endostapler. Of course, endostapler may be cost. In that case, you can do a lap assisted. Just take the jejunum out and the stomach out through a small opening made, and you can do the anastomosis with a stapler outside with only 1.5 inch to 2 inch incision and put the whole thing down. And that makes every sense. So this is something that we would like to discuss. So before I end today, these are the important topics that you must read. Number one, as Viva topic, H. pylori and its treatment. I have not gone into the details. I can spend hours talking about how these things change, but for your purpose, you must be able to do the inflammation and the alkaline reflex biofeedback mechanism in terms of H. pylori. This is a common X-ray and all of you are well acquainted with that. But again, my humble submission is, the problem is you cannot make any mistake in a peptic perforation X-ray or a hollow viscous perforation X-ray, because the examiner knows that you know everything of this, starting from the description to the underlying cause and the causes. The third is a specimen of stomach. And again, you are going to get a stomach specimen cut open. As I said, as we discussed, you must be able to tell the ulcer character, the rugal convergence, and whether the rugosity is effaced or not. And this is extremely important. As a long case, you are going to get gastric obstruction, as I showed and as we discussed. And in operative surgery, truncal vagotomies and gastrojejunostomies remains an important operative cheat. Gastrectomies, yes, we will discuss when it comes to operative. In instrument for gastric benign or acid peptic disorders, you must be well acquainted to staplers, because that is something which is the standard of care now, and you must be able to tell about staplers of different types, be it endostaplers, and we now have the advanced endostaplers, as well as the standard linear cutters that we use. And in occlusion clamp, you have pairs, gastric occlusion clamp, to something as intestinal or gastric occlusion clamp that we have. So that again is important. So as you understand, these are 5 important topics or 6 important topics which comes as under acid peptic disorder. And so I end here. I saw Rudra entering. If there is any question, you can put it in the chat box. I will be happy to answer those questions. Any questions? Hello?
Sir, if the perforation is analgesic induced, why we should not do emergency operation, sir?
No, I didn't tell I should not be doing an emergency perforation repair. What I told is that you should not be doing, as I said, an emergency definitive procedure in terms of phlebotomy and gastrojejunostomy because it's an acute ulcer. I mean, either analgesic or steroid, these are acute onset ulcers, and you should not be doing a definitive phlebotomy, pyeloplasty, or a phlebotomy gastrojejunostomy. Okay? Next question.
Sir, in
So,
cases of
Rudra,
vomiting, how to differentiate practically whether it's the content is gastric or bilious, as both of them appears to be yellowish in color.
oh, that's an interesting question. As I said, we were discussing this somewhere here or maybe here. Yes, or the pattern. I mean, when you are dealing with biliary vomiting, bilious vomiting, they will be greenish, they will be bitter in taste, and the patient is going to tell that after they vomit it in the sink or whatever place it is oily and greasy. Whereas if there is a gastric outlet obstruction, it is going to be completely whitish. It may contain undigested food material. It is sour in taste, and wherever they vomit, they will leave behind a stain of the acidic stain. So this is how you differentiate between a bilious vomiting and the vomiting of gastric outlet obstruction.
Thank you, sir.
Thank you very much.
Sir, if it is malignancy, it will be projectile kind of vomiting, no, sir?
Now, a projectile actually is whether it will be projectile or it is going to be close by depends on so many factors. If there is an absolute occlusion, whether it's benign or it's malignancy, they might give rise to a sort of projectile vomiting. But the classical projectile vomiting is not a nomenclature which you should be using for adult cases. In certain cases, superadded on malignancies, you might have a pylorospasm where they can have one or two episodes of projectile vomiting. But you are going to carefully avoid the term projectile vomiting in adult cases during your exam. You are going to tell the patient vomits out. If they force you to utter, are you going to call them projectile? You are going to tell, sir, occasionally the trajectory is away from the body. But classically, I won't call it because none of them will have a classical projectile vomiting which occurs in a complete pylorospasm. Okay?
So could you please repeat the part where definitive surgery is done in perforation case?
Okay. Let me go to this. Yes. Or maybe here only. This is some other slide. I got a space here, so I'm writing it here. Now, if you're dealing with a peptic perforation, there may be two reasons. One is it is caused due to acute cause like analgesics, steroids. In these cases, the question of vagotomy, gastrojejunostomy doesn't arise. It is out of question. So you're not going to do it. Now a patient comes with a chronic duodenal ulcer in whom there is a perforation. And chronic duodenal ulcer, the only available thing is from history. The patient has been suffering for 3 years, 4 years, have been taking pantoprazole, they have been persistent vomiting, and during the month of fasting has gone into fasting and it has perforated. Now these cases, the question of in single sitting, are you going to do the surgery or not? It depends on the general condition of the patient. Number one, presentation less than 12 hours. Age less than 40 years. Okay. So if you find this and there is no comorbidity, so actually it is said the outcome of a perforation surgery depends on three things. Number one, the duration of perforation, the age of the patient, and comorbidity, and each approximately contribute roughly 1/3 to the morbidity and mortality. So if the patient comes to a young age, non-hypertensive, non-diabetic, and the duration is 6 hours, then only, apart from the perforation repair, you can choose to do a truncal vagotomy or a pyloroplasty or a truncal vagotomy or a gastrojejunostomy. You can get that extra time, but or else you are not going to do. So in acute cases, no. In chronic cases with late presentation, no. Did I make it clear?
Yes, sir. So all the three things has to be present.
Yeah. If it satisfied the criteria, then yes, or else no. Then of course it depends on your expertise. I mean, if you take 4 hours to do a vagotomy gastrojejunostomy in an emergency, you are in the first beginning step of your traineeship. You should not be attempting that. Only, now what has happened is, as vagotomy gastrojejunostomy is becoming a rare surgery, vagotomy is something which even the junior consultants have not learned. So it's a sort of dicey situation, and therefore, unless you are not trained and all the criteria is fulfilled, avoid doing a definitive surgery. Okay.
Thank you, sir.
What are the
Your voice is cracking, dear.
Sir, what are the three types of pyloroplasty? Sir, Jubulis pyloroplasty, Venous pyloroplasty. What are that? What are the techniques?
I mean, I am telling you what is pyloroplasty. Now, this is another page. Forget about that. Now, what happens in pyloroplasty is you need to make this wide because you have removed the vagus. So you need to make it wide. So there are 1001 method. One is you cut it like this. So if you cut it like this and then you suture it like this. So if you cut it like this and suture it in this direction, then the whole thing becomes wider. You cut it and you suture it in this direction, so it becomes wider. So there are techniques you can, the classical HF is this. There are people who have done YV plasties. So there are so many ways, umpteenth number of techniques by which you can make the pylorus wide. And this comes under the classical HM, Jaboli, all of them. But the main type of pyloroplasty that people advocated at one point of time is Fine, where they would make a linear incision from the pyloric end going up to the duodenum. And then you are going to join this with this, and the anterior similarly with the anterior. So that would mean that the stomach is overlapped by the duodenum, something like this. So that means it becomes a gastroduodenostomy. So this is the Finney's one. So during the exam, try to remember, nobody is going to ask you this question, but still the Heineke Mikulis and the Finney's. These are the two classical pyloroplasties which people used to do 2.5 decades back when they used to get only ulcer cases without gastric outlet obstruction. Okay, any other questions? Okay, so I hope there is no other question. Shilajit or Rudro?
Yes, sir.
Yeah, Shilajit, you can conclude the session.
Okay. So thank you, sir.
Okay.
Good night, sir.
Good night.
Thank you, sir.
Thank you very much. If you have any question, do put it in the group. And later on, we have a class on gastric surgery as such, where we are going to discuss more in details. And there are complications of gastric surgery should be one class itself, because every complication that you have will have a question. Okay. Now, if I can give you a quiz about gastric surgery, just a quiz for all of you. Anybody who can raise your arms and give an answer. Now, a young gentleman had got a gastrojejunostomy done when he was at the age of 27 years. And now he comes back at the age of 40 years with severe sudden onset pain, colicky pain in the upper abdomen associated with a lump and a vomiting which is slightly darkish in color. What is your diagnosis? Anybody who can guess?
Recurrence, anastomotic ulcer or recurrence, if
Anastomotic
there was
ulcer.
any cancer.
Good. Now, as I said, the patient has. Sorry. Now, this patient had a truncal vagotomy, gastrojejunostomy done when he was 27. Now he has come at the age of 40 years. He is complaining of severe colicky pain with a lump here. Pain, lump, vomiting, and it contains dark, altered coloration. And on examination, you find a lump. The pain is colicky in nature and this is acute onset. In a recurrence, you are not going to get, as you said, a lump. So what else it can be?
GJ site block.
So one suggestion was an ulcer. Somebody suggested it was a block. Now, if there is a block, again, how do you explain the lump?
Sir, internal herniation.
Internal herniation. After 13 years, it's a rare entity, very, very rare entity. And getting a lump again may not be very common.
Sir, anastomotic site ulcer which had preceded and now it has turned malignant.
But that will be a chronic event. Here is a gentleman who was absolutely fine and things started only 2 days back. Okay, but as I said, CA, anastomotic line, for chronicity, yes. Stretch your imaginations, it's not a physical class, or else I would have offered you a toffee. And yeah? Who was that guy? Once again, please repeat your diagnosis. Yes. The diagnosis. Can you identify yourself? What's your good name?
Chakravarti.
Who told that it's an intersusception? Who told intersusception?
Sir, I'm Dr. Rajni from Jamshedpur.
Okay, and you are from which place?
Sir, Jamshedpur.
So yes, bang on. The answer is retrograde jejuno gastric intersusception. Clear? So the answer is the GJ side, the jejunum has gone inside. You do an X-ray or a barium study, you are going to find a beautiful loop superimposing on the stomach. And this is a retrograde jejunogastric intersusception. Okay, so I give another. So let us give another quiz. Clear? Everybody ready? This is the last quiz of the day. I know most of you are waiting for your food. Now, this is again a gentleman who had undergone a surgery for a vagotomy gastrojejunostomy. That was again, say, on 27 years back. 27 years age, now he is 42. He has presented to you for last 3 months with pain, vomiting. He doesn't have a lump. And the vomitus contains fecal smell. What is the diagnosis?
Gastrojejunopolic fistula.
Yeah?
Gastrojejunopolic fistula.
Excellent. The diagnosis is gastrojejunopolic fistula. Very good. So you understand, these are the questions that you are asked even in OSCE, and you need to prepare yourself in that direction. So thank you very much for participating in these two quiz, and I would request Shilaji to close it for today. And I must congratulate once again Apple and Zoom for ending their conflict and allowing